Okay, good afternoon, everyone. Welcome to today's webinar. I see people are just kind of trickling in, so I wanted to give you some time to get settled before our presenters start. So we're probably going to get started around 1:02. Thanks for your patience. Good afternoon and welcome to the webinar, CHC in Southwestern Pennsylvania, updates about how it is going for consumers. I'm Kayla McNally, the Project Administrator at the Pennsylvania Health Law Project, and I'd like to quickly review a few items so you know how to participate in today's event. You can submit questions to today's presenters by typing them into the Q&A pane of the control panel. You may send in your questions at any time during the webinar. We will collect and answer them throughout. Today's webinar is being recorded. If you have technical difficulties at any point, please hang up and dial back into the webinar. If the problem persists, you can email me at event, E-V-E-N-T, @phlp.org. And now I'll turn it over to today's presenters, Janice Meinert and Erin Gay.
Thanks, Kayla. All right, good afternoon, everybody. Thank you for joining us. We appreciate you being here with us. I'm going to get us started. We'll take a break at least probably once through my part of the presentation, stop for questions. If there are any burning questions before that, Kayla can just flag them for us. And then Erin's going to pick up on the second part of the presentation. So the first part of the presentation is what might be review for a lot of people, depending on you know, how involved you've been up until this point in community health choices. So just a minute or two for anybody who's not familiar with us at the Pennsylvania Health Law Project. We're a statewide nonprofit law firm, and our work focuses on helping people access public health insurance programs and services through those public health insurance programs. So primarily working with folks who may be uninsured or underinsured, and in particular people who are on or eligible for Medicaid, as well as low-income Medicare individuals. So you see our helpline number on there. We also have a staff email that folks can contact us directly. Anybody can call us, the individual themselves needing help or somebody on their behalf. And then in addition to our direct client work, we also do a lot of work in terms of education, things like today's webinar, lots of written materials on our website, and then from our individual work, we also do a lot of systemic advocacy, in particular at the state level with the Department of Human Services. We have a monthly newsletter that comes out electronically. Folks that aren't getting it, that may like to get it, just email us at staff@phlp.org, and we'll make sure we add you to that list. Okay, so what we're going to cover today, as I said, we're going to do some community health choices basics that for some folks might be information you already know, give you some updates about community health choices, an overview of some of the problems that we're seeing through our clients that they've experienced or still are experiencing with community health choices, and then give you a couple of resources that could be helpful to you. So just a very basic 101 on Medicare and Medicaid, and again, this might be familiar for most people, though we recognize not everybody's submerged in this day-to-day as typically we are here. So we'll be talking a bit about people who have both Medicare and Medicaid. Medicaid is a state federal funded program that is means-tested health insurance, meaning people have to be eligible, typically by income, and Medicare is the federal health insurance program. Medicare is specific to people who have worked, paid into the system, and turn age 65 and older, or people who may have worked, paid into the system, then become disabled, start to receive Social Security disability insurance. After getting that for 24 months, those individuals become Medicare eligible. Also, people who may have a diagnosis of end-stage renal disease, on dialysis, or who have had a kidney transplant, those individuals as well could be eligible for Medicare. And folks who have both Medicare and Medicaid, often referred to as dual eligibles. Okay, so let's talk about community health choices. So what is it? It's the name that the state gave to its fairly new Medicaid managed care system. So it did not replace the Medicaid health choices system that we've had in place over, a couple of decades in Pennsylvania now. It's an additional Medicaid managed care system that affects certain groups of people, and we'll do a brief review about that. And the Community Health Choices program specifically covers long-term services and supports for some groups of people on Medicaid, and we'll talk more about that, and for those who are eligible for those services. And it also covers Medicaid physical health services, not behavioral health. And again, we'll talk more about that. And covering the long-term services and supports can include both in the community, what typically we've referred to as waiver services, as well as people getting long-term services and supports in a nursing home, paid for by Medicaid. Okay, so who's impacted by community health choices? Couple different groups of people that are impacted. First, individuals who are dual eligibles, who have both Medicare and Medicaid. Exceptions being that Community Health Choices is for individuals 21 and older. So there are some people under 21 who are eligible and have both Medicare and Medicaid. Those folks are not a part of Community Health Choices until they become 21. And if at that point they still have both Medicare and Medicaid, and depending on where they live in the state in terms of the rollout, they would then be enrolled in Community Health Choices, or CHC. Individuals who may have both Medicare and Medicaid, but are in one of the state's 3 intellectual disability waivers, or the autism waiver, or perhaps are getting services through the county ID system, even if they have both Medicare and Medicaid, those folks are not and should not be enrolled in Community Health Choices. So who else is impacted by CHC? People who were receiving waiver services through one of the Office of Long-Term Living's home and community-based waiver programs. Those waiver programs are for people who are aging, considered 60 and older, or people with various physical and some developmental disabilities. Exceptions, there are several waiver programs in Pennsylvania. People, again, in the intellectual disability waivers, in the autism waiver, they are not enrolled in CHC. People who might be receiving services through the LIFE program, and we'll talk a little bit more about what that is, do not become a part of CHC. And individuals who were in the OBRA waiver, who are not determined nursing facility clinically eligible, do not go into CHC. Individuals who were in the OBRA waiver prior to each CHC phased rollout, who are all reassessed to determine if they're nursing facility clinically eligible, if they are, then those folks do go into CHC. And nursing home residents. People in nursing homes being paid for by Medicaid are a part of CHC. Exception being any state-operated veterans homes. Those folks in those nursing facilities are not a part of CHC. Okay. The rollout of CHCs happened over a 3-year time period. January of last year was the Southwest rollout. What you see is phase 1 on the PowerPoint. This past January was the rollout in Southeast, 5 Southeast counties. Next January will be the rollout of CHC for the remainder of the state. So phase 1 was about 85,000 people. Phase 2 about 130,000. Phase 3 will be closer to 140. So that will actually be the largest, both as we can see, obviously geographically, in terms of CHC rollout, as well as the number of people that will be impacted. CHC is operated through 3 managed care plans. The state contracted with 3 of what were 14 applicants back in 2017. 3 plans were selected. Those 3 plans are AmeriHealth Caritas, Pennsylvania Health and Wellness, and UPMC Community Health Choices. They are the plans throughout the state. So no matter what region, what phase somebody's in, what region they're in, they have a choice of the same 3 plans. In the Southeast, AmeriHealth Caritas calls itself Keystone First, but it's the same plan, just a different name. The state, and in particular Office of Long-Term Living, it still maintains oversight for this program. Ultimately, they're responsible for the program. They're still required to monitor and are, of course, monitoring the program. And the state is paying a capitated rate to these plans for each of their participants. CHC plans have to cover all of the Medicaid services for adults, physical health services, and then for those eligible, they're also responsible for payment of long-term services and supports, whether those services are provided in a nursing home or in the community. Okay. So what's the role of the independent enrollment broker in community health choices? Folks may be familiar, even prior to community health choices, with the state's independent enrollment broker. That entity right now is Maximus. They have been and still are responsible for helping people apply for home and community-based waiver services. And in this case as well, basically apply, if they're not already enrolled in CHC, to apply for getting home and community-based services through CHC. So that's still the point of contact. That's who people call to start that application process for themselves or a loved one who's at home, whose health is and physical condition perhaps is declining, needs help with assistance with activities of daily living, want to see whether that individual is eligible to get help through the state. That process still starts with a phone call and going onto the website to start the application process for long-term services and support. Once people are in CHC, the independent enrollment broker, Maximus, is also responsible to help people understand the program, provide them with some basic information, explain to people the 3 plans, the 3 community health choices plans that they can choose from, help people enroll in a plan, help people switch a plan if they want to change their plans, because people can do that at any point in time. And they're also the entity responsible for, sending out, initial and subsequent mailing. So as the rollout starts to gear up for the rest of the state, the phase 3 for January of next year, it's the role of the independent enrollment broker to start to send those mailings out to all those folks that are going to be impacted by phase 3. As I said, once somebody's enrolled in a Community Health Choices plan, they are allowed to change their plan at any time and can change their plan, as often as they want to. Not recommended just to do, but people are allowed to change their plan at any time and as often as they may need to for various reasons in terms of just accessing services or in particular the providers that they want to access. When somebody can change their plan or when that becomes effective depends on, when they make the change. So it's the second Thursday of every month, typically around mid-month, but not necessarily exactly the middle of the month. Whatever the second Thursday of each month is the deadline to switch plans in order for that plan change to be effective for the following month. So, for example, for June, somebody wanted to change their plan now, anytime between now and June 13th, then that change would be effective for the 1st of July. Somebody makes a plan change after the second Thursday of the month, then that new plan won't be in effect until the following month. If somebody needs to change their plan and has a reason that it really needs to happen quickly, then that's also a possibility. People call to change their plans with the independent enrollment broker, with Maximus. So they notify Maximus, let them know that they need to change their plan. If they need that to happen sooner than the usual time frame, they should notify Maximus of that, ask that that request be sent to the Office of Long-Term Living. Generally, people are going to need to provide a reason. Perhaps somebody ends up with see the doc sends you the specialist wants to do a surgery or a procedure, but then realize that that specialist is not in your, that person's CHC plan, and the surgery perhaps is scheduled or needed quickly. That's perhaps an example of a situation where somebody could call Maximus, let them know they need to change to one of the other two plans, and could ask for that change to be expedited. When somebody changes their plan from one CHC plan to the next, if they were receiving some type of service that had been prior authorized by the plan they are leaving or have left, then the new plan has to honor, that course of treatment, for up to 60 days. So if I happen to switch plans, in the middle of physical therapy, perhaps post-knee replacement surgery, and that physical therapy's been approved for 3 times a week for 4 weeks, I switch plans in the middle of that, my new plan still has to honor that authorization I received from the first plan for that physical therapy, but only up to 60 days. And then after that, then the new plan has a say. If the individual is changing plans and they are receiving long-term services and supports in the community, waiver services, then whatever services are in their service plan, when they change CHC plans, those services have to be honored until the new plan does a new face-to-face assessment with that person and develops a new person-centered service plan. But the new plan could, initiate that as quickly as they want to. And that's certainly a piece for people to keep in mind, if they're changing plans and they are receiving in-home services, they're getting waiver services. I think it's important for people to know, if they're changing plans because of a specialist or a doctor, a medical provider, but they're also getting waiver services, they do want to keep in mind that what their current plan has approved could certainly change once the new plan comes in and does their own assessment at whatever point they may do that. I mentioned earlier the LIFE program, and the LIFE program separate from Community Health Choices. People enrolled in the LIFE program are not enrolled in a Community Health Choices plan. And in fact, for some people, LIFE might be the only alternative to Community Health Choices. In order to be eligible for LIFE, people have to be 55 and older. They have to be determined nursing facility clinically eligible. They have to meet the income and resource limits for the program. And they have to meet, and the clinical criteria being NFCE. They also have to have a LIFE program available in the area where they live. At this point in Southwest PA, in the Southwest zone of 14 counties, we are almost, I think, with the LIFE program in every county and in every zip code at this point. So that's, and as we move in, that's always an alternative for people who meet all the criteria. The LIFE program is itself a managed care program. It's all-encompassing for people, whether they have Medicare and Medicaid or just Medicaid. It provides all of their physical health services, all of their behavioral health services, hospital care they may need, nursing home care that they may need, and all of their community supports that they need. So whether those are in-home waiver supports or services offered at a center that the LIFE program operates, all of those persons' needs are all part of the LIFE program, and they're accessing all those services through the LIFE program providers. So people are not able to, access some doctor or specialist, whoever it might be, outside of those that are already a part of the LIFE program. So what's covered under CHC? Physical health services, and for those eligible and in need of, long-term services and supports. So the vast majority of people enrolled in Community Health Choices have Medicare as their primary insurance. Nothing changes about that with CHC. If they have both Medicare and Medicaid, Medicare always pays first for any Medicare covered service. Medicaid is the secondary insurance, and Medicaid and the CHC plan is responsible for any physical health services that somebody receives. Behavioral health services are not a part of Community Health Choices. The behavioral health system as it exists, the managed care system as it exists in Pennsylvania for 25 years, remains the same for people in Community Health Choices. So folks in CHC have, in addition to likely having Medicare, they have Medicaid with the CHC managed care plan, and they have for physical health services, they have their behavioral health services through a Medicaid behavioral health plan. That plan is determined by the county in which they live. That is, and on the behavioral health, within the behavioral health system, people don't have a choice of their behavioral health managed care plan. It's determined generally by the county mental health office that holds that contract with state oversight, and in some cases, the state holds the contract directly, the State Office of Mental Health and Substance Abuse Services. So, and you can see on your slide, depending on what county somebody's in the Southwest zone, determines, what their behavioral health plan is. So how do people access behavioral health services in CHC? Again, those services are accessed through their behavioral health managed care plan. One of the changes that CHC brought for some groups of people, specifically people in a nursing home paid for by Medicaid, as well as people who prior to CHC or going into CHC were in the aging waiver, those groups of folks were not in a behavioral health managed care plan prior to Community Health Choices. Once enrolled in Community Health Choices, those individuals now are also enrolled in a behavioral health managed care plan. So all of those folks should have been, provided with information, should have received a member handbook from their particular behavioral health managed care plan. And there are actually, a few additional services available to people as a result of now being enrolled in a behavioral health managed care plan. Again, vast majority of people in CHC have Medicare primary. So when they're accessing behavioral health services, they need to be keying into both their Medicare and their Medicaid coverage and their Medicaid behavioral health plan, and access providers who take both of their insurances, for any mental health or substance abuse services that they need that is covered by both Medicare and Medicaid. Sometimes we see instances where this presents problems for people. It seems especially to be problematic when people are trying to access outpatient mental health therapy, where there's a difference in credentialing for mental health therapists on the Medicare side versus the Medicaid side, with the Medicare side having higher credentials for therapists. So because Medicare pays first, and Medicare can't, people can't just not have their Medicare be billed for services that they're behavioral health services they're trying to access, and they do need to find, providers who are, certified under Medicare as well as under Medicaid with their behavioral health plan. People in CHC who are getting long-term services and supports that are having difficulty or just have questions about, how do I get behavioral health services, they certainly can call their behavioral health plan directly, and they also can ask their service coordinator for help, again, especially for the vast majority that have Medicare primary. They may need additional assistance in trying to find, a provider that takes both of their insurances. Okay. So what's covered under Community Health Choices for people getting long-term services and supports? The CHC plans have provider networks for all the various services covered for long-term services and supports. That includes, of course, nursing homes, as well as, a really broad array of services available to people in the community who've been determined eligible for long-term services and supports. So people are, accessing those services by, contacting their CHC plan or making sure with their CHC plan that the services they're trying to access are from a provider that is, in the network, has a contract with the CHC plans. The services people get in terms of long-term services and supports all stem from an assessment that's done initially, a face-to-face assessment, and from that assessment is developed a person-centered service plan. So that those services that somebody identifies as needing or wanting have to be written into their service plan, have to be approved by their CHC plan before they can, access those services. The CHC plans get to decide how service coordination is provided within CHC for people getting long-term services and supports. And they also get to decide how the nursing home transition services are offered. One of the big differences with Community Health Choices from the prior waiver system, the Office of Long-Term Living waiver system, is that service coordination in and of itself was a service provided, in addition to many other services, depending on which waiver somebody was in. In CHC, and it was deliberately designed this way for perhaps better or worse, the service coordination is not considered a service. It is an administrative function of the CHC plans. So they get to decide, whether they only hire their own internal service coordinators, if they use service coordinate or contract with service coordination entities in the community, offer a combination of both, but that is up to the CHC plans. Service coordinator is huge in helping people who are getting long-term services and supports, get those services, coordinate services, all of their services, across Medicare, Medicaid, behavioral health. The Office of Long-Term Living has really been very clear about the significant role that service coordinators play, and certainly had a significant role in the waiver system, but even much more so under Community Health Choices, really looking to them to be, the go-to person for that person receiving long-term services and supports, on a variety of issues. I'm going to stop here. That's been a lot of information. Kayla, I'm going to check with you to see if we have any questions coming in through the Q&A box.
Yeah, it looks like we have one question, and then we'll give folks a little bit of time to get their lingering questions in. So someone asked, is there an accurate provider search tool with CHC? There have been several inaccurate network provider searches that resulted in participants having to give up a service or provider of choice to keep something else. What is the best way to provide accurate information for participants?
Well, people should be able to access the information from the enrollment broker website and from the individual CHC plans website. I guess the caution being that, if the plans are not keeping those websites accurate, then there's the possibility that, somebody makes a decision about a provider or even about a plan, and ends up having a problem because that provider that they want to access services with, is not in their CHC plan or in the CHC plan they want to enroll in or switch to. Really, probably that's the place to start. It is the CHC Plans website or the independent enrollment broker website. But I think to be most sure, I think we would always encourage people to call the provider directly and to be sure that provider is in fact in the network of the plan they're in, or perhaps the plan that they're looking to switch to.
Okay, we have another question. Someone asked, I have a client that is in CHC LTSS coverage with UPMC. There was a billing dispute and the client filed a complaint with UPMC. The client has also received a U.S. Treasury notice stating that 15% of his SSI benefits will be withheld. Can anyone advise to how this can be successfully challenged?
Well, I'm thinking, or at least hoping, that those are two separate issues: the billing issue and with the CHC plan with UPMC, and with the SSI issue. The billing issue, if they filed a complaint with UPMC and the issue was still not resolved, I would refer those folks to our helpline, the 1-800-274-3258. People in any of the Community Health Choices plans, with the exception of what could be, really very small co-pays for some services, should otherwise not be seeing bills. I mean, they really shouldn't, they could be charged a copay of, 50 cents to see a therapist, or $1, or, a doctor appointment. Beyond that, people should not be getting billed. Hopefully not, as long as they were accessing providers that take their insurance, or in the case of people with Medicare, as long as it's a Medicare provider and a Medicaid enrolled provider. So in this case, it didn't need to be a UPMC CHC provider. It just needed to be a provider that, if the person also has Medicare. The issue with what sounds like perhaps an SSI overpayment, that's something that I would refer somebody to the local legal aid. That is not our expertise. We help people just on the Medicaid, Medicare, health insurance side of things, and we do not have expertise in Social Security benefits, or in this case, what sounds like an SSI overpayment. If for any reason those two things are connected, the bill and the SSI overpayment, I just can't possibly imagine. There should not be any scenario where those two things have anything to do with each other. But I would certainly, I would either contact us on behalf of the client, or have the client contact us directly.
Okay, and that's all the questions I'm seeing for right now.
Okay, great. Thanks, Kayla. All right, we're going to move on a few more slides, and then I'm going to turn the reins over to Erin. So what isn't a part of CHC or hasn't been changed by CHC? Medicare, and I think we've said this before, and I know in prior trainings, I think we tried to be as clear as possible about this. People have, majority of people in CHC have both Medicare and Medicaid. Nothing about CHC changes their Medicare. Medicare is still their primary insurance. People still get to choose if they want Medicare with just their Medicare card, if they want a Medicare Advantage plan, if they want to enroll in a Medicare Special Needs plan, specific to people who have both Medicare and Medicaid. Nothing about CHC changes Medicare. People still have their choices. As we've said, the LIFE program, it kind of exists alongside CHC for people who are LTSS eligible. People enrolled in a LIFE program do not also get enrolled in a CHC plan. The options program, the Act 150 program, those are state-funded only programs that provide some in-home services for people who are, options is 60 and older, and Act 150 for people with physical disabilities. Those programs still exist in Pennsylvania. people who may be getting services through those programs and aren't otherwise, a dual eligible, for example, are not enrolled in CHC. But those programs still exist in Pennsylvania, still there to provide services for people, often for people who don't otherwise qualify for in-home waiver services. As we said, people enrolled in the autism waiver or one of the 3 intellectual disability waivers, those waivers still exist. Those folks do not get enrolled in CHC. How people qualify or are eligible for Medicaid or for Medicaid, home and community-based services, or for Medicaid to pay for their nursing home care, none of those things change. The eligibility criteria, clinical criteria for waiver or nursing home, financial criteria, none of that changed. CHC did not impact any of those things. Okay. So what about transportation with community health choices? In the rollout in the Southwest last year in particular is where we absolutely saw a lot of confusion about, how individuals in CHC were to be accessing transportation services. The Southeast rollout seemed to have less issues, which was a good thing, of course, but definitely saw some of these issues in, with the Southwest rollout, and again, last year in particular. So the CHC plans are responsible for some transportation. Each of the 3 CHC plans have chosen to work with transportation brokers, AmeriHealth and Pennsylvania Health and Wellness using the same broker, MTM, UPMC using a different broker, CTS. So the CHC plans in terms of transportation where nursing home residents are concerned, are responsible for all of their transportation. And by responsible in particular, we mean, responsible to pay for it. It doesn't mean that the CHC plan is necessarily scheduling or organizing the transportation for nursing home residents. The nursing home staff could be doing that, and that's fine. They just, are coordinating those transportation services. Typically, in the case of somebody needing to go, to a doctor appointment outside the nursing home, go to the hospital, go to the emergency room, whatever it might be, the CHC plan is responsible for paying for those transportation services. Outside of folks in nursing home, people in the community, the CHC plan is responsible for ambulance transportation. So somebody's at home, has an emergency that is, determined that they really need to call an ambulance for. Again, folks have Medicare primary. So in that case, Medicare may be paying first, but then the CHC plan is, is also responsible for payment of medically necessary ambulance transportation. CHC plans are also responsible for what's defined in the contract as specialized non-emergency medical transportation. So some folks, for example, can only get to medical appointments if, in a stretcher van, not necessarily an ambulance, but need, to be in a stretcher and transported in a vehicle that accommodates a stretcher. That falls to the CHC plan's responsibility. And for folks who are getting long-term services and supports in the community, they can also access non-medical transportation. So that could be for things like, going to a job or a job interview, going to anything that might be included in that individual's person-centered service plan. And that's a really important piece, that people can only access non-medical transportation, a ride to church perhaps, a ride to, weekly Tuesday night bingo, because that's a part of, you know, the social goal in their plan. It's spelled out in their plan, in addition to the need for transportation to be spelled out in the plan. When that's approved in their plan, then it's the responsibility of the CHC plan to make sure that happens. Medical assistance transportation, as it's always existed for a long time in Pennsylvania, still exists. That still operates, you know, alongside the transportation responsibilities that fall to the CHC plan. So what about folks' appeal rights in CHC? People have a right to file both what's termed a complaint as well as a grievance with their CHC plan. A complaint is generally kind of how we think of the word, a complaint. So a CHC participant has an issue with the plan itself, has an issue with a provider, has an issue with something that perhaps is not a covered service, you know, anything that they may be having a dissatisfaction with or a problem with, an unpleasant encounter with a provider. Those are all considered complaints, and people have a right to file a complaint. Grievances have to do with a denial of service. So if a CHC plan denies something that's requested either in, you know, by a physician, something that might require prior authorization, or something that's been requested in terms of long-term services and support, something somebody's identified as wanting or needing in their service plan, you know, if that service is being denied, then people have a right to file a grievance. When a service is denied, the CHC plans have to provide a denial in writing, have to provide people with their appeal rights in writing. Those notices should always include contact information for the Pennsylvania Health Law Project's helpline number, as well as for legal aid services. If somebody is denied a service, they can appeal that denial and have to appeal it first through their Community Health Choices plan. That appeal is termed a grievance. If somebody is appealing a denial or a reduction in services, and we're seeing these primarily so far regarding people getting in-home personal assistance services. If somebody's been getting X number of hours a week of personal assistance services, they have a new assessment, a new service plan developed, plan decides that the hours they have been getting are not needed and they're going to approve something less than that. If somebody, again, they're entitled to get that in writing. It's really not effective unless they get it in writing. If that participant appeals that notice within 10 days, then they're entitled to keep getting the services through the appeal process. So 10 days is the important time frame for people to get continued benefits pending the appeal process. They, in fact, have 60 days to file a grievance once they receive a denial notice. And as I said, the grievance has to be filed first. That's an appeal process within the plan itself. Once they appeal, if they appeal to a grievance, have a grievance decision, that grievance decision is one they're still not satisfied with, then people have a right to file a fair hearing in addition to an external grievance. Time frame to file the fair hearing is 120 days. Appeals can also be expedited because there are time frames once somebody requests the appeal, then both in the case of the plan with the grievance or the fair hearing with the State's Bureau of Hearings and Appeals, there's time frames for when those grievances or fair hearings have to happen. If people feel like their health would be harmed by waiting out the normal time frame, people can request an expedited grievance. Okay. So let's talk a little bit about dual eligibles and how they access care in community health choices. And then I apologize, and then we're going to have a couple of examples. So and right now we're looking at somebody who's getting, who's in CHC because they have both Medicare and Medicaid, and aren't necessarily getting any long-term services and supports. So again, most physical health services and behavioral health services are covered by Medicare. So the CHC plan is paying secondary to whatever Medicare Part A, their hospital coverage, or Medicare Part B, their outpatient medical coverage. So the Medicare is paying first, CHC plan is paying second. People who have dual eligibles have prescription drug coverage through Medicare, through their Medicare Part D plan or through their Medicare Advantage plan that includes Part D covered drugs. So it is their Medicare plan covering their prescriptions, exception being somebody who has a prescription for an over-the-counter medication. Excuse me, Medicare is not required to cover that. Medicaid with the CHC plan can and does cover that. And the CHC plans are also responsible for paying secondary to any Medicare Part B covered drugs, not to be confused with Part B. So example is, somebody who gets a medication injection at a doctor's office. That doesn't fall under Part D as in drugs, it falls under Part B as in boy. That's only covered 80% by Medicare. The CHC plan is then responsible to pay the difference. CHC plan covers, as we said, physical health services. People might have small copays for those services, and again, small as in $1 at the most, generally, for any service. CHC plan can't impose any rules, prior authorization kinds of rules for any service that Medicare covers. Medicare is the driver, Medicare is the primary insurance. And then, as we said, the CHC plan doesn't cover mental health and substance abuse services. The individual's behavioral health managed care plan does. And again, in the case of the duals, Medicare is paying first. So people are accessing services through providers, hopefully, that take both their Medicare and their behavioral health plan. Okay, so we're going to run through, not all of these examples. Okay, we're going to run through a couple of examples and quickly, I think, just because I want to make sure we leave enough time for Aaron and the second part of the presentation. So Jack is a dual eligible. He's in CHC, he has both Medicare and Medicaid. His Medicare is just original Medicare, meaning he's using just his red, white, and blue Medicare card. He doesn't have any Medicare Advantage plan, Medicare Special Needs plan. He uses just his Medicare plan, and then he has additionally a Medicare Part D drug coverage. His CHC plan is UPMC. He has a neurologist, a rheumatologist, and a dentist that he's seeing routinely. So in terms of the neurologist, the rheumatologist, he's making sure, hopefully, that those docs take, his Medicare and are also Medicaid enrolled. Because he's got Medicare primary, that neurologist, rheumatologist, any other physical health doctor he sees doesn't have to specifically be enrolled in his UPMC CHC plan. The doc has to be Medicaid enrolled and Medicare enrolled because, of course, that's his primary insurance. What about access to the dentist? Medicare doesn't cover dental services. His Medicaid CHC plan does. It's a fairly limited benefit, but nonetheless, he has dental benefits. So in the case of seeing a dentist, he does need to see a dentist that is enrolled with his CHC plan and wants to make sure that his dentist is enrolled in his CHC plan You know, otherwise he ends up with, you know, potential problems or getting billed. Okay. So the dentist has to be in the network. The other, of his CHC plan, the other providers don't have to be in the network, but do have to be Medicaid enrolled. So that's the case of Jack. Now let's look at Patty. Patty's also a dual eligible, only she doesn't have Medicare in just with her original Medicare like Jack does. She's got Medicare with United Healthcare Dual Complete Special Needs Plan. So that's a plan, a Medicare plan specifically for people who have both Medicare and Medicaid, and she's in a CHC plan with AmeriHealth. She has some health conditions, diabetes, and heart problems. So for things like her doctor visits, primary, you know, physician, specialist she might have for her diabetes, her United is her Medicare, her United pays first, her AmeriHealth CHC pays second. Again, that doc, that lab facility, the person doing the lab work does not have to be. It might be ideal. It might make for, you know, easier billing and less hassle for her, but she does not have to see, you know, a provider, you know, or get lab tests done with a with a provider enrolled with CHC, as long as it is a provider that's Medicaid enrolled, and in her case takes her Medicare plan, which is United. She's got diabetes, so she has, you know, diabetes testing supplies. That's typically covered at 80% by her Medicare. So in her case, the United's paying first, and the AmeriHealth CHC plan is billed and paying second. In all likelihood, taking medication for perhaps both her diabetes and her heart condition. That's, you know, that's a Medicare covered you know, service through her Medicare, and in this case, her United, because her United is covering her Medicare Part A benefits, her Part B benefits, and her Part D benefits. So it's just her United that she's concerned about. Because she has both Medicare and Medicaid, the copays for her medication should be low. Lower when they're generic, a little higher when they're brand name, but she qualifies for the extra help. So she shouldn't have copays for any of her medications that exceed, you know, $8 and change. Okay. And now let's look at Rita. Rita's 84, again, a dual eligible, has both Medicare and Medicaid, has some health conditions, high blood pressure, and having some recent issues with incontinence. She's also dealing with depression and anxiety. So, you know, lots of different health conditions and needs related to those health conditions. She's got original Medicare. She's got Medicaid with a CHC plan with AmeriHealth, and then she has value behavioral health based on the county that she lives in. So she's, you know, going to any health provider that takes original Medicare, because that's what she has, you know, for most of her services. Again, the AmeriHealth CHC plan is going to cover secondary to her Medicare for any Medicare covered services. Physical health services, her behavioral health services, and hopefully, you know, getting treatment or trying to access treatment for her depression and anxiety. Her behavioral health providers, perhaps a psychiatrist, perhaps a therapist. Those providers need to accept both her original Medicare and her behavioral health managed care plan. Prescriptions that she may, you know, medications she may be prescribed for high blood pressure, for her depression perhaps, and anxiety, those are all covered through her Medicare Part D prescriptions. I'm sorry, her Medicare Part D drug plan. She's now dealing with incontinence issues. So her PCP can prescribe adult diapers for her. That's not something Medicare covers. That is something that Medicaid covers through her CHC plan. So she wants to access a medical supplier, through, in her case, the AmeriHealthcare to CHC plan. She can, and the best way to make sure she does that is, if she doesn't already, have a provider, she can ask that she contacts her CHC plan, AmeriHealth, and finds out, what medical suppliers that provide incontinence supplies are in their network. Different medical suppliers provide different medical services. So what are some of the issues that we've seen for dual eligibles in terms of, access to services with CHC? Certainly, and especially initially for folks, just confusion. And confusion for the participants, confusion for providers, people just not understanding, what happened and what was happening with the change in their health insurance when they became enrolled or chose or not a CHC plan. Some people are having problems accessing providers. Again, especially early on, and we saw it again more in the Southwest and the Southeast. That might be a matter of, lessons learned from one zone to the next so that things went smoother. But certainly with the Southwest, we saw a lot more confusion with providers as well as participants. So, providers were not clear that as long as they were Medicaid enrolled and, were a Medicare participating provider, that they didn't have to be enrolled in their, in their patient's CHC plan. As a result, we certainly saw people getting billed for services. We saw some folks who were denied access to providers because the providers thought they had to be in the CHC plan, in order to continue to see, their patient. So lots of confusion and conflicting information that again impacted both participants, and the providers. So, what are some solutions for some of these? Depending on how, people have their Medicare, people who are enrolled, dual eligibles who have Medicare and a Medicare Advantage plan or special needs plan, can contact that special needs plan to try to, get clear about making sure they're accessing providers in the network, and perhaps can even be helpful, between them and the CHC plan regarding, billing issues, billing protections when people have both Medicare and Medicaid, and see providers that accept both Medicare and enrolled as a Medicaid provider. They're not to be billed. We know it happens. We know people get billed, but they do have balanced billing protections. They are not responsible for those bills. And both the Medicare plan and the CHC plan can help people, in accessing providers. For people who are dual eligibles and also getting long-term services and supports, and having problem accessing those providers, they really should be working with their service coordinator as well as their CHC plan. People having problems getting billed, having problems with access to providers, being told they can't see a provider that perhaps they should be able to. People always have a right to file a complaint with their CHC plan. People not getting resolutions with any of, with these issues through Medicare, through their CHC plan, through their service coordinator, folks certainly should feel welcome to call us at the Health Law Project helpline. Right, I'm going to turn it over to Erin, but I'm going to check first with Kayla to see if there's any questions.
Nope, none yet. Okay. Nope, no questions.
Okay, great. All right, folks, that's enough here from me. Wait.
Sorry, one question. Somebody has entered a question.
Go ahead.
They ask, is PT or OT included as a benefit for all CHC plans?
PT and OT, yes, they are Medicaid covered services. Typically, I believe, have to be prescribed by a treating physician. But yes, physical therapy and occupational therapy are Medicaid covered services for adults. Therefore, they're part of the benefit package through CHC.
Okay, and then that's all the questions for now.
Okay, great. Thanks, Kayla. All right, folks, I'm going to turn it over to Erin.
Thanks, Janice. Hi, everyone. All right, so I'm going to continue talking a little bit more about just some other challenges that duals are facing and some possible solutions, and then we're going to talk about some of the other populations and the problems they're having. So something that we've seen, and this kind of crosses all of the populations in community health choices, is the participants who need help with communicating with their CHC plan and want family members or advocates to help them, that people have had a real tough time when the family member, daughter, sibling, parent, in the case of an adult child with disabilities, when that person tries to contact the CHC plan. You know, the plans always cite HIPAA, whether that's valid or not. So in order to have participants, in order to get help talking on behalf of the participants to the CHC plan, there are some options. So there's authorized representative forms that each of the CHC plans have that can be completed and signed by the participant, giving their permission for the CHC plan to talk to anybody the participant wants to be able to talk to the CHC plan. If somebody has kind of more formal legal authority for that person, such as a power of attorney or guardianship, those papers should be submitted to the CHC plan, and then the CHC plan should be talking to anybody that has legal authority for somebody in CHC. So we encourage folks to get those forms filled out and to not only send authorization forms to the Community Health Choices plan, but also submit authorization forms to the county assistance offices. The county assistance offices have their own authorization forms, but if somebody's listed as an authorized representative in the CAO system, that gets transferred to the CHC plan, and then the CHC plan should recognize that person as an authorized representative and talk to them without needing some additional paperwork. And we know when people call us and we call the plans, you know, if we do a three-way call with somebody, that also helps. But we know clients are nonverbal, they maybe aren't available with somebody to make the call with them. So again, these forms are a way to kind of make sure people can communicate with the plans, especially when the participant isn't able to help them communicate with the plan. So Janice talked about some of these challenges with coordinating care between the insurances when somebody has Medicare and Medicaid. So there's different requirements that Janice talked about, especially on the behavioral health side. But there can also be challenges because Medicaid, CHC, is the payer of last resort. So oftentimes we hear from people that need a service, and if they have original Medicare, you know, the CHC plan isn't going to authorize something until Medicare denies it, but original Medicare doesn't have a prior authorization system. So there's no way to kind of get a denial from Medicare before a service is provided. And this comes up a lot with durable medical equipment and some other supplies, because the Medicare rules are that Medicare gets billed when the service is provided. And the provider is not going to give the service when they don't know who's going to pay for that service. So there can be a lot of challenges about coordinating care between insurances. So just some possible solutions. Again, contact the Medicare plan. If somebody is in a Medicare Advantage plan, that may be able to do a prior authorization or issue a denial before services are provided. For folks in original Medicare, they can contact the Community Health Choices plan, and that Community Health Choices plan is supposed to kind of help coordinate, and they should be doing something to move the situation forward to get the individual the services they need. And people can also file a complaint with the CHC plan that means then that this gets raised up to a different level. The plan has to investigate it, has to issue the outcome of the complaint in writing, and then some complaints, if there's no resolution, people do have further complaint options to kind of pursue and appeal that. Another reason filing complaints might be helpful is because that helps the state monitor things, because plans have to report complaints and grievance information to the Office of Long-Term Living. So I think if the Office of Long-Term Living and their monitoring sees there were a bunch of complaints about problems accessing care or coordinating insurances, that's hopefully going to flag that as a bigger problem that has to be dealt with in the course of the monitoring of the CHC plan. So I think I talked about this, but people have problems getting medical supplies, medications. There's a lot of confusion about what's covered, who's supposed to be covering things, finding providers that take both somebody's Medicare coverage and I guess is willing to work with the CHC plan if they're not in the network. And again, the same solutions: contact Medicare coverage, contact the CHC plan or the service coordinator. And for folks when they're at the pharmacy, we hear about this a lot from people getting diabetic testing supplies at the pharmacy, where the pharmacy usually bills their Medicare coverage, but then it's coming back with a copay of $20 or more. And for some reason, the pharmacies don't routinely bill the Medicaid coverage as secondary to reduce that person's charges. So just make sure people are asking if the Medicare coverage is paying through the Medicare Part B as in boy system, that the pharmacy is asked, they shouldn't have to be asked, but they can be asked to bill the Medicaid coverage as secondary, which should reduce the cost to the consumer. Or if somebody's trying to get an over-the-counter medication that would be billed to the Medicare Part D coverage, but Part D doesn't cover over-the-counter medications, oftentimes clients tell us, that they're charged the full amount for that medication. And the pharmacy doesn't necessarily prompt them to ask for Medicaid cards or CHC cards. And sometimes people end up paying for medications that should be covered by their CHC plan. So always ask the pharmacy to bill Medicaid for meds that aren't covered or for items at the pharmacy that come back with a significant copay that would be more than somebody on Medicare and Medicaid should be paying. So those are some additional challenges. And we know some of these solutions, unfortunately, we don't have clear, do this and this will be resolved. Everybody that's working with folks in CHC knows that every situation's different. There's a lot of nuances to this. And I think we learn case by case kind of what steps should be taken and kind of how to resolve a problem. So I know it's a little bit frustrating that there's not some one-size-fits-all solution, but hopefully trying some of these things or, referring folks to us at the Health Law Project, we can try to help address and get people's situations fixed or moving in the right direction. So switching to the next population of folks in CHC, let's talk a little bit more about the folks who are getting long-term services and supports at home. Janice talked kind of about some parts of how this is supposed to work. For this population, again, most people in CHC have Medicare as their primary health insurance. But for folks who are getting long-term services and supports at home, a small percentage of folks in CHC don't have Medicare. And so CHC is their only health insurance. It's a couple thousand people that are getting LTSS at home and don't have Medicare as their primary insurance. So these folks, they have to follow the CHC plan rules to get care. They might need referrals to see specialists. They might need to have tests or services prior authorized. They might have to get prescriptions prior authorized or kind of go through the formulary rules in a way that dual eligibles don't have to do. This hasn't been a problem so much in Southwestern PA, at least that we've seen, but we have heard of some challenges in Southeastern PA for this population that are having medications maybe that they've been on for months or years denied by the CHC plan. Again, Janice talked about how the CHC plan develops provider networks, both in terms of the physical health coverage and the long-term services and supports. There's broad services available through CHC, so kind of all the different waivers that existed pre-CHC that went away and got combined into CHC. So the aging waiver, the attendant care waiver, independence waiver, all of those programs had different services that they covered. And CHC covers the whole broad range of LTSS that were previously available through any of the existing waivers that were replaced by CHC. But things are still based on need, and so just because somebody could get respite or could get home delivered meals or home modifications, somebody still has to have a need for the services available in order for it to be covered through CHC. And we know that there's been some challenges with some of the new services like pest eradication that the state had been touting as being available through CHC. There's been a big challenge because those entities that do pest eradication, they're not medical providers, so they're having a hard time getting people enrolled as Medicaid providers to provide this service. So that's been a little bit of a challenge for folks that need help with pest eradication. Participant direction is still available for some services. So this allows people who want to hire their own workers and not go through the agency model. So that does still exist for personal assistance services. I think it's possibly available for respite. So that's still available, and people are still able to hire and fire their own workers. There's also another participant direction option known as Services My Way that's available under Community Health Choices. And this is for people who really want control. They figure out what their needs are, and then a budget gets developed, and then a spending plan is developed in order to figure out how to spend their budget on services that would meet their needs. So it's just a way of giving somebody more control over their services under that Services My Way option. And again, the in-person assessment and the person-centered service planning process determines the services. Again, this is based on the person's needs, what their goals are, what informal and formal supports the person has available to meet some of their needs, and what they continue to need help with, even with the supports available. And again, the big difference is that the CHC plan is the one that approves the services and pays providers. And we're going to talk about some of the challenges, but these plans outside of Pennsylvania Health and Wellness had not been involved in providing long-term care coverage and paying for long-term care coverage before CHC started. And even with PA Health and Wellness that had that experience in other states, there's still a lot of challenges with participants kind of getting needed services or providers getting paid through this system. So we just wanted to kind of highlight some requirements in terms of time frames for people getting long-term services and support, so people are aware of these rules. Like Janice talked about, an in-person assessment is needed to get services when there's changes needed to services. Everything kind of hinges on an in-person assessment to start the process, and then a service plan is developed from there. So there are time frames for certain situations to guide how quickly an in-person assessment has to happen. So the CHC plans have to do an in-person assessment within 5 business days when somebody is new to getting home and community-based services, when they're new to CHC. So we know CHC has been in place now for almost a year and a half. There's new people coming into this system every day. So if you're working with somebody who was newly approved for home and community-based services by Maximus and by the County Assistance Office, once they get approved clinically and financially, then they are immediately enrolled into a CHC plan if they weren't already on Medicaid. And then if they're supposed to be getting long-term services and supports, an assessor is supposed to contact them and come out and do an in-person assessment within 5 business days. And I think we are concerned that this doesn't seem to be happening as quickly as it's supposed to given these time frames, because we've heard of some people kind of being newly approved and it being weeks before they hear anything from an assessment or as an assessor a service coordinator and to schedule the assessment. And then if there is a dual eligible who is in CHC and is either identified by themselves or by the independent enrollment broker as having an immediate need for services, for long-term services and supports, that CHC plan is supposed to have an in-person assessment done within 5 days in that situation as well. Then there are some occasions where an assessment is required within 15 business days. So this is the time frame for any participant that has an unmet need, a service gap, or a need for service coordination. So this might be somebody who's getting long-term services and supports, but maybe, that's not meeting all their needs, or maybe they now need home-delivered meals when they didn't need that before. So any unmet need or a service gap might be if they were working with an agency and then their worker quit the agency and the agency doesn't have any other staff. If they're kind of going without services that they should be getting, that would be something that should be brought to the attention of the service coordinator for sure, or the CHC plan if there is no service coordinator, and that should trigger an assessment within 15 business days. Again, there are dual eligibles. Most people in CHC are simply dual eligibles not getting any long-term services and support. And any dual eligible can flag themselves as needing service coordination to the CHC plan, and that should also then trigger an in-person assessment to figure out what is needed to meet that person's needs that they have. And then a participant or their representative can request an in-person assessment, and when that happens, that's supposed to happen within 15 days. And then there are some events that are called trigger events that also should result in a reassessment taking place. And the time frame for these trigger events, the assessment is supposed to happen within 14 days. So this is when somebody, mainly somebody who's been getting long-term services and supports, when they've maybe gone to the hospital or come out of the hospital, or maybe somebody who was in a nursing home and went to the hospital. That should all be triggering a reassessment by the service coordinator. Other changes, like changes in functional status or changes in their caregiver informal support status, or changes to their home setting or environment, or changes in their health condition. All of those changes, when that change kind of results in a significant impact in their health situation or limits their functioning in a way that is different from how they've been functioning up till now. All of this should trigger a reassessment within 14 days. So we all know caregivers might get sick, caregivers might have to travel for work, or maybe they have to deal with other family members who are having some problems. There's lots of changes that could happen to somebody's caregiver informal support situation. We also know that people sometimes run into problems with their housing. Maybe they're having water or sewage problems, or their heat went off. Kind of anything like that should be brought to the attention of the CHC plan, of the service coordinator, and this should all be triggering a reassessment to figure out what additional services are needed to help address the situation. And then people can also request to have a reassessment done, or a caregiver or provider could request this. So I know the previous slide said when a participant requests it, it's supposed to happen in 15 days. This slide says 14 days. We can't explain the discrepancy, but this is how it's laid out in the agreement that the CHC plans have to follow. So just to talk a little bit about the person-centered planning process that, again, is supposed to guide the services that people get through CHC. This is a central component to CHC. And there have been problems with the CHC plans kind of following the process that the state laid out. The plans are all in corrective action and have been for a number of months related to person-centered service planning. So we're just wanting to make sure people kind of understand what's supposed to happen and mainly kind of what the rights are of the participant in this process. So everything is to be centered around the participant, kind of what their goals are, what their needs are. So the participant, when they meet with the service coordinator to develop a person-centered service plan, the participant has the right to include anybody in that meeting that they want, whether it's a friend, a neighbor, a relative, somebody they know from church. Anybody can be included who the participant wants. And then the participant should be the one identifying what their goals are. And then together with this team, they're supposed to come up with the services needed to meet those goals. And everybody's goals are different. You know, older adults might have the goal to stay living independently in their home that is near family. Younger people may have goals that they want to be able to go back to work, or they want to be able to do more work than they've been doing right now. People might have goals that they want to get out and go to bingo every week, to be social and to be with their friends, or to go to church or other events. So everybody's goals are different, but it's the participant that's supposed to drive the goals in this process. And then participants should always be given a copy of the service plan. They should always have the chance to review that service plan before they're asked to sign it. And participants should always sign the service plan. And on the service plan, they can agree to the services and the information in that plan, or they can disagree with it. And any disagreement noted should trigger an appeal. And I think this has not been happening. At the beginning of CHC, you know, there were no goals in people's service plans. People were not given copies of their service plans. People weren't signing them. So I think things are better now than they were before, but I think we still have some really strong concerns about plans not following this process the way they're supposed to. And at the end of the presentation, you know, we link to our website. Janice created a really great guide that talks about the person-centered planning process and kind of helps consumers, family members, advocates kind of really think about what they want and to help them prepare for the person-centered service planning meeting. So I encourage people to check out that publication. So let's just kind of go through some examples about people getting long-term services and support. We're picking up with Rita that Janice started. So Rita was a dual eligible. She was in CHC. She was having some health problems. And so Rita's declined further, and now she needs help to remain living at home in her apartment. So Rita has some family close by, but they can't meet her needs because they have jobs, they have families of their own, and they can't be available to help her as much as she needs it. So Rita contacts Maximus. She's found nursing facility clinically eligible. She gets approved for home and community-based services through CHC. She's in AmeriHealth, so she chooses a service coordinator through them. Within 5 days of being found eligible for the in-home support, Rita and her daughter meet with the service coordinator who does an assessment and develops the person-centered service plan. And then Rita starts getting long-term services and support. In her case, she gets approved for 7 days a week of home-delivered meals, and she gets approved for 4 hours a day of personal assistance services. Another example, and this example is of someone who's just on CHC, doesn't have Medicare. So Peggy is 62. She has multiple sclerosis and other health problems. She needs help with all activities of daily living and help with shopping, kind of housework, those sorts of things. She only has Medicaid. So her health insurance is her UPMC CHC plan, and then her behavioral health coverage is through Value. Because she's not on Medicare, she has to use the UPMC Community Health Choices network of doctors and other providers, and she has to follow all the rules that UPMC CHC plan has for her to access care. Her long-term services and supports are also through UPMC. She has a UPMC service coordinator, and Peggy's service plan includes 12 hours a day of personal assistance services. She gets home-delivered meals. She has the personal emergency response system. And then her service plan also includes some non-medical transportation to take her to church and to take her to a book club every month so she can continue to be involved with her friends. Another example is an example of somebody who has a change in their caregiver status. So Archie is 79, and he gets help with most of his activities of daily living, bathing, dressing, getting in and out of chairs, in and out of bed. And his wife is the one who provides most of his care, but she needs help taking care of him, even though she's able to help him with some things. So Archie's in Pennsylvania Health and Wellness, and they get an additional 4 hours a day of personal assistance services to help Archie with bathing, dressing, and exercises. Archie's wife falls at home, and she has to be hospitalized. So in this case, because his wife isn't available like she was before, his service plan should have a backup plan to meet immediate needs. So there should be something in place in the event that the wife wouldn't be available that should kick in now that she's had this fall. But the triggering event of the caregiver becoming more limited or having a change in the caregiver status also should be triggering the service coordinator to come out, do a new assessment, and figure out what other services might be needed while his wife is recovering. And maybe she's not going to be able to help him at all or nearly as much as she was before. And so his service plan would have to be updated and submitted to the plan for approval. So those are just some kind of examples. I'm sure you all have other examples as well. Let's just talk a little bit about some of the challenges and problems that people getting home and community-based services or LTSS at home through CHC have been facing, at least based on the calls that we've been getting. And again, I think the caveat is that when people call us at the Health Law Project, no one calls us when things are going well. People don't call us and say, Erin, I just wanted to let you know everything's going great, I'm getting all my needs met. So we only hear about problems. And certainly we don't hear about all of the problems people are experiencing. So please feel free, if you have other information that you want to share, please chat that in, and so the group listening today can hear those other problems. Or if things are working well, I think it's probably important to share that information as well. All right, so we still have some communication challenges with folks getting services at home. A big challenge is for the plans that are still contracting with outside service coordinators. Those service coordinators don't have access to the CHC plan system, so it can be really hard for them. You know, they put a request in for new services or different services, and then the service coordinator can't access the system to check on the status of that request. And so I know they try to follow up with the CHC plan, and oftentimes there's delays in kind of getting responses from the CHC plan. And this is a real challenge because the CHC plans are working with these external service coordinators, but not giving them all the access they need to kind of fully help that participant or be able to give updates to the participant about where things are. Again, the same problem with representatives or other people besides the participant who need to contact the CHC plan. Another area where we've seen some challenges is when people are transitioning kind of to CHC or between CHC and a different program. So we've had some folks contact us who have been in the OBRA waiver and who are turning 21 and transitioning to CHC because most of them are nursing facility clinically eligible. So that's been a challenge. There's been challenges when people have been moving from community health choices to the LIFE program, but more often it's when people want to leave LIFE and come into CHC and trying to get everything in place so that services are available through CHC on day one. Because people getting these home and community-based services can't have a gap in services where they're not getting that in-home help that has been keeping them independent. There's been some challenges when people maybe are moving to the ID system because maybe they're a dual eligible and they have not been getting base services and a slot becomes available in the ID system, trying to coordinate that so that it's a seamless transition. The state has developed some policies to address some of these situations. Certainly more work is needed, but I think if you're working with any folks that are kind of in these transition periods and kind of things are moving slowly or they're just kind of left in the dark and not knowing what's happening, we encourage people to call the Office of Long-Term Living Participant Helpline, who can who should be aware of the situation and maybe can help move things behind the scenes and get things moving in the right direction. There have been lots of access to service issues for people who get home and community-based services, and the problems relate to various issues. So we've certainly seen some problems with the assessment document that's being used to determine kind of people's needs. And this is especially true for people with cognitive challenges and dementia. So the tool doesn't really capture a lot of information about their dementia or cognitive impairments. It doesn't really capture adequately the need for safety and supervision. For people who need queuing help, sometimes that's hard to fully have documented in the assessment. And then as a result, services are cut or people aren't getting approved for the level of services they need. Again, there are lots of problems with the person-centered service planning process. You know, we've had clients who have contacted us where the service coordinator has come up with the goals instead of the participant. We still are seeing service plans where the goal information is blank, or people aren't given copies, or not having the opportunity to sign those documents. We've seen service denials, mainly from Pennsylvania Health and Wellness, some UPMC service denials. We don't think that means that AmeriHealth isn't denying services, but we're not seeing them. Lots of transportation issues, lots of confusion, like Janice mentioned. People are being told that they can't get help through CHC when they should be getting help with transportation through CHC, or folks are being sent to medical assistance transportation program and having problems with that system. One challenge is that there's no timeframes in the rules for how quickly plans have to review requests for services, for long-term services and support. And so we've seen people have really lengthy delays in terms of maybe getting services reauthorized, or in the case of home modifications, this process seems to be taking months. And even after a request gets submitted, sometimes the plans are taking a really long time to act on that request and make a decision and get a notice out to a consumer. People haven't been offered a choice of service coordinators the way they're supposed to. And then it still seems when people have an urgent need for services that there's not really a clear process. And sometimes the service coordinators, those internal to the plan as well as external, aren't clear on kind of what the process is to get things acted on quickly and get services in place for people. So just some possible solutions. Again, in a lot of these situations, people can file complaints with the CHC plan and have this investigated, have their problem investigated. When services are denied, we really encourage people to file grievances. It just requires a phone call. You don't have to request a grievance in writing. Again, appealing quickly within 10 days keeps the benefits going. But if somebody is denied a new service and there's a really urgent need for that service, ask for their appeal to be expedited. We have, based on the people that have called us and folks that we have represented, as well as folks that we haven't represented but have talked about their situation, people are getting good decisions at grievances. Not always, but in a lot of cases that we've seen during the grievance process, the person or their advocate or their family member is able to provide some additional information for the grievance panel to hear, and then that results in services being restored or some additional services being given. So again, not in every situation, but in a number of situations, people have gotten positive outcomes from the grievance process. Again, on some of the delay issues, if the CHC plan isn't being responsive, reach out to the Office of Long-Term Living Participant Helpline or contact us, especially for service denials. We're happy to at least advise people, and we've been really trying to make an effort to help represent people in these grievances to help them improve their chance of success. So feel free to reach out to us about any of these challenges or others people might be experiencing. The other issues we wanted to mention, and again, folks are probably aware of some of these on the call, but a lot of the service coordination entities that had been doing service coordination are having their contracts end with the CHC plan, and that's causing some disruption for consumers who have been working with service coordinators, especially those that have had long-term relationships with some of these service coordinators whose contracts with the plans are ending. And then for people that need information in other languages besides English, or for folks that have vision impairments, they have a right to information in Braille, audio cassette, large print, and I think people are struggling to get kind of language in other information in other languages or in alternate formats. So again, it's really important for people that need information in alternate formats or other languages. If the CAO knows about that, that information gets in the system and that should be communicated to the CHC plan, or people can make the request for other information directly to the CHC plan, and they should be acting on that request. So I'm going to take a break here before launching into the last section about nursing home residents, but I wonder if there's any questions that came in, or if anybody had any comments or other examples of things working well, other problems.
Yeah, so it looks like we have a few questions. Someone asked, do CHC service coordinators have to authorize DME for CHC to pay for it in addition to the doctor?
Well, so I think if somebody needs DME, a prescription is needed, and then the plan has to usually authorize it. So I think, and this is a good question, because I think there's some durable medical equipment that is covered by Medicare and Medicaid, and there's other medical equipment that is only covered by the waiver. So I'm thinking like a lift chair, right? Like a lift chair, the lift mechanism is covered by Medicare and Medicaid, but the chair itself is covered by the CHC LTSS benefit package. And so in those situations, something would have to be in the service plan, and then the CHC plan has to authorize that as a service in order for the LTSS benefit to pay for it. So usually the CHC plan does have to authorize some piece of medical equipment. Yeah, good question.
Okay, next question is, does the CHC service coordinator give the participant a copy of their service or care plan?
Yes, our understanding is the service coordinators are supposed to be giving copies of the service plan to the participants. Yes. But I guess if the person asking this is a service coordinator for a CHC plan, please reach out to them because they dictate what you do. But our understanding is it's the service coordinator, because that's who meets with the participant, is the one giving the service plan to the person.
All right, the next question is, when services are denied by CHC plans, are participants usually given a reason for that denial?
Yes, well, the denial notice, if they get the denial notice in writing, like Jana said, they're required to. The notice is supposed to give a reason as to why the service is being denied. And it should be something other than you've been assessed to need these services. There should be some further explanation. And if no further explanation is being given, please let us know or have the person contact us, because initially when the continuity of care period ended last summer, the CHC plans were starting to reduce services and not giving explanations or reasons for that decision. And that's not allowed, that's not okay. So we were able to raise that to the state, and the state immediately halted denials and put the plans in corrective action. So the state is, well, not corrective action for the denials, but they made the plans do some additional steps to be able to issue denials. And so the state is confident that they're all issuing denials appropriately with reasons being given. So if you're seeing that's not the case, please let us know so we can follow up about that.
The next question is a CHC service coordinator a mandated reporter or a voluntary reporter for protective services?
Oh, yeah, that's a good question. Oh, and I think Yeah, I'm not sure. I want to say yes, but I'm not 100% sure that's correct because, again, we're not experts really in the protective services system. So if this is being asked by a service coordination entity, I think you want to follow up with your management or with the CHC plan maybe. And we'll look for information after the call, and if we can find something, we'll certainly send it out to everybody participating today. So sorry, we can't really answer that definitively.
Okay, someone has a question about one of the case studies that you shared, the one for Peggy. And so they're asking, how does Peggy qualify for CHC when she is not a dual eligible?
Okay, good question. So Peggy qualifies for CHC because she's getting home and community-based services. So for people getting home and community-based services or for people in nursing homes, they don't have to be a dual eligible, but most of them are. So again, you know, Janice covered the population. It's dual eligibles, people getting long-term services supports at home or in nursing homes. So there are some folks that are at home getting long-term care or in nursing homes getting long-term care, where they're on Medicaid because they're eligible for Medicaid, home and community-based supports, or Medicaid coverage of nursing home care, but they're not on Medicare yet. And so that's okay.
All right, the next question is, how often does a CHC service coordinator contact the resident?
Okay,
The second part of that is, are they required to follow up monthly?
Yes, that's a good question. And I think, if I'm remembering what the agreement says, I think they're supposed to make monthly contacts, right, like by phone. They have to see people every so often. But I think, again, if this is a service coordinator asking this, I think they want to follow up with the managed care plan, because the managed care plan should set out what the requirements are in terms of frequency of contacts with participants. But I thought I saw something in the agreement about monthly contacts, at least with, yeah. And again, we can double check that and send something out to folks if there is a rule about this, which I think there is.
Okay, that seems to be all the questions for now.
Okay, great. You're all asking very good questions. We just have a couple more slides to go through. I know that this is a lot of information, but I think your questions help, and if we're not addressing them completely, we'll follow up about some of them, and then again, please reach out to us separately or have consumers reach out to us, and we can try to look into things further. Okay, so lastly, we wanted to just talk about community health choices for nursing home residents. And to be honest, we're not getting a lot of calls about this. So I don't know if anybody on the phone can provide any input about how things are going for nursing home residents. But all nursing home residents on Medicaid get community health choices. Again, the CHC plan provides their Medicaid physical health coverage and then pays for the nursing home care. The behavioral health and drug and alcohol coverage is covered through the Health Choices Behavioral Health Plan in the county where the person lives. When someone's in CHC, they still have to pay their patient pay amount for the nursing home care. That doesn't change. You know, Janice talked about this, that eligibility for Medicaid, long-term care, and regular Medicaid doesn't change with CHC. So it's the county assistance offices that are still kind of doing the renewals every year and adjusting the patient pay amount based on the person's situation. Everybody in a nursing home in CHC has a service coordinator that works with that nursing home from the CHC plan, and that service coordinator works with the nursing home staff to make sure that the residents' needs are being met. When people are in nursing homes, the nursing home is responsible to make sure they get the care they need and that their needs are otherwise met. And sometimes people get most of their care from the nursing home, but there might be situations where somebody needs to get care outside of the nursing home, you know, maybe to see a specialist or to get some testing done. And so when they leave the nursing home, It's their health insurance that pays for the care that they get. So again, most folks in nursing homes are on Medicare. That's going to pay first for most of the services they get out of the facility. And then it's the Community Health Choices plan that pays for their physical health care, and behavioral health plan paying for their behavioral health or drug and alcohol services. So just an example of a nursing home resident. Phil is 80 years old. He lives in Sunnyside Nursing Home. He's a double amputee and has had a heart transplant. He has Medicare and Medicaid. In Phil's case, he has Advantra Medicare Advantage plan. He gets Medicaid through Pennsylvania Health and Wellness, and then his behavioral health is through Perform Care because that's who covers the county he lives in. He has a service coordinator through Pennsylvania Health and Wellness that works with Sunnyside Nursing Home and works with the staff to make sure Phil gets what he needs. And then he sees a specialist in Pittsburgh. So the nursing home arranges the transportation to get him to his medical appointment, and that's paid for by the Pennsylvania Health and Wellness plan. The transportation is, and then Advantra and Pennsylvania Health and Wellness both cover the specialist visits. So that's just kind of a quick example about how CHC works for folks in nursing homes. And so just some of the problems we have heard about, again, this family members or other people being able to communicate on behalf of the participant with the CHC plan. That's kind of an ongoing problem across these different population groups. There seems to be a lot of confusion about nursing home transition. And again, Janice talked about the fact that the CHC plans decide how they're doing nursing home transition. So they're doing it all differently, and I think in some cases they're not using the entities that had been doing nursing home transition before. So basically, I think you're supposed to let the nursing home know about you're wanting to leave the nursing home. That's supposed to trigger the nursing home service coordinator getting involved, who should be working with another service coordinator to help set up a service plan and get services in place so that they are in, so that somebody can leave the nursing home and on day one of being back in the community that they get services. And I think people are experiencing some delays and lots of confusion or getting conflicting information about this process. People have been struggling to get specialized durable medical equipment when they're in a nursing home. Again, a lot of this is related to coordinating between Medicare and Medicaid. I talked to a nursing home where the resident needed a special wheelchair that kind of tilted and lifted, and Medicare didn't cover that kind of wheelchair. And so the CHC plan was not doing anything because they couldn't get a denial from Medicare. And so we had to get, the Office of Long-Term Living involved to be able to tell the CHC plan kind of what the process should be to authorize that equipment for this person in the nursing home, and they were able to get it approved through the CHC plan. But a lot of back and forth with the supplier, with the insurances, and then with the Office of Long-Term Living ultimately. And then again, transportation has been a problem. Again, we heard mostly about this at the beginning of CHC. We haven't heard about it so much lately, but I think we're not convinced that that doesn't mean that there's not problems happening. And we heard just some kind of really concerning stories about Lyft and Uber drivers going to nursing homes to pick residents up when CHC first started to get them to medical appointments. So hopefully the process is working better, but certainly if any nursing home resident is having a problem with transportation, and there's a need for some additional assistance, please reach out to us. Okay, so there's a lot of areas where the system still needs to improve for sure. We talked about some of these successes. I guess we can call them successes in terms of leading to the plans to delay being able to deny services or reduce services. They're still kind of improving that person-centered service planning process. We and other advocates have pushed the state to develop policies and processes regarding nursing home transition, transitioning between programs that has improved things somewhat, but certainly there's more work that's needed. And then another problem that people experienced at the beginning of this year in Southwestern PA who are in CHC, any dual eligible who gets services at home through CHC should get extra help, like Janice talked about, and they should have a zero copay for their medications through the extra help. At the beginning of the year, there was a glitch in the system that communicates kind of what the copay amount is to be for someone's extra help. It resulted in people being charged small copays when they were not supposed to have any copays. So we heard from a number of folks in January and February that had to pay for prescriptions at the pharmacy when they didn't have to do that last year, and they shouldn't have been charged copays this year. So that was fixed as of March. Anybody getting home and community-based care through CHC, if they're a dual eligible, their extra help should be at a zero copay level for medications at the pharmacy. Again, that was corrected as of March going forward, but we still have clients that have not been refunded for copays they paid in January and February, and that is supposed to have happened automatically. So again, if you're working with anybody who is still needing refunded for medications they bought at the beginning of the year, please reach out to us so we can try to get their situation fixed and addressed. Okay, just some contact numbers for places we've talked about already through the course of the presentation. And then just making sure if people aren't already on the state's listserv for CHC to get on that listserv, because that's how you learn about any developments or new information related to CHC. And again, check out our website. We have the person-centered planning document that's really helpful, and we have some fact sheets to help people appeal CHC denials. So that's the information we wanted to cover. I'm sorry, we thought this was not going to take anywhere close to 2 hours, and here we are pretty much at the 2-hour mark. But we did want to see if anybody had final questions that we can try to address while everybody's on the call here.
Yeah, so far there's just one question, but maybe more will trickle in as people enter them. The question is, have there been any issues with people accessing behavioral health care?
Yeah, there has been. I think a lot of it stems from this problem where the Medicare criteria for who can be a therapist is stricter than the Medicaid criteria. So we've had consumers who are dual eligibles just have a challenge finding somebody that takes both their Medicare coverage and their Medicaid coverage. Yeah, and that's not a new problem, but we've definitely heard of that kind of continuing to be a problem with CHC. Janice, any other problems?
Yeah, I guess I wouldn't say problems, but we don't have a good sense yet of, as I talked about earlier, folks going into CHC who are nursing home residents and people who were in the aging waiver. Those folks were able to access behavioral health services, but just with the access card in what's called the fee-for-service system. With CHC, the state decided to change that, and those folks are now enrolled in behavioral health managed care plans. Again, you know, specific to the county that they live in. So we're not really hearing about problems, but we're also not really hearing yet is being enrolled in the behavioral health managed care plans, you know, has that increased services that people are getting? Are people clear even, you know, how they access the services now? I mean, we know that people were provided with information, a member handbook for their, you know, appropriate behavioral health managed care plan, but we don't really yet have a sense of, you know, are folks that were in the aging waiver, folks in nursing homes, you know, are they aware of, are they getting assessed for, are they in fact getting any or more services, mental health or substance abuse, than they were before. So that's, you know, that's definitely a, you know, to be continued area, and one that, you know, even us at the Health Law Project need to be zeroing in on, you know, a little bit more.
Yeah. And Janice, what are some services that are new to people, you know, who are in this population?
Well, there are some new, some I think just easier to access. So, for example, I remember having a client in the aging waiver who was trying to get Medicaid paid for, a behavioral health therapist, mobile therapy, a therapist that comes to them. That's covered under the fee-for-service system in the same way it was covered if people were in the behavioral health managed care system, but we could not find a provider who would take just the access card. Behavioral health managed care plans, physical and behavioral health, tend to pay a little better than the state does directly through the access card. So, you know, there should be improved access, you know, for people. And then there are also, you know, there are some services, specifically on the drug and alcohol side, people that had Medicaid and still may with just the access card. You know, there are some levels of drug and alcohol services. A drug and alcohol halfway house, for example, you know, is a service that's not covered under Medicaid fee-for-service that is covered under the behavioral health system. And, you know, so there are, you know, both additional services as well as some that, you know, should be easier to access, in large part because people have a place to go now. They call their behavioral health managed care plan and find out, if they don't already know, you know, what are the range of services available and who are those providers that I can access them from.
Okay, thank you.
We get anything else, Kayla?
Yeah, it looks like there's just a comment, someone said, the biggest challenge I have is quality of care provided by the home care provider. Either their service hours are not being fully provided or the aides are not following the service plan.
Yeah, it's a problem we didn't touch on, but one I think that's, you know, that's familiar. I mean, certainly if somebody has hours, you know, personal assistance hours typically, you know, approved by their CHC plan, you know, and in their service plan that, you know, are not being met. You know, people have a right to file a complaint. People have a right to work with more than one agency. Erin talked about this is one of the services that, if willing and able, this is a service that people can self-direct, meaning that, you know, they can do that in combination with agencies, or they can do it all themselves, so that if in fact somebody does have, you know, a trusted individual, friend, neighbor, relative, whoever, that's willing to provide some or all of their services, and that participant is able, you know, to hire them, you know, that's another potential option. But you know, across the board, and we see it here, not just, you know, where long-term services and supports are concerned, but kids who get home health aides, kids that get skilled nursing. Unfortunately, you know, it's an issue across the board. It's a staffing issue. That I'm sure is multifaceted. You know, it isn't probably just that often these folks aren't paid well or paid enough for the work that they're doing. It's hard work. It's work that isn't appealing or just a good fit for a whole lot of people. So it's a problem. But again, you know, at a minimum, people have a right to be filing a complaint and talking with, you know, if their service coordinator is not being helpful, you know, looking at what, maybe that's a new service coordinator, or getting even to, you know, service coordinator, supervisor, or just calling the service coordination unit. Some plans even have direct lines to their service coordination unit to say, you know, what else can be done here.
Yeah, and I think as far as the aide not following the care plan, I think that should be brought to the attention of the agency. You know, there should be a manager or someone overseeing that aide, even though they're not in the house with them, but that should be brought to the attention of a higher up within that agency to get addressed. And the service coordinator should definitely be aware of that too, so that that person can also try to help get that situation addressed.
Right, absolutely. If there are whatever needs are part of that service plan, that person's to be, you know, assisting with laundry or meal prep or whatever it is. Somebody needs their food cut up. That's and those things aren't happening, that absolutely, that's, as Erin said, possible ways to address it.
Okay, there's one more question, and then I think we'll call it.
I know we're over.
Can an aging waiver participant's spouse be paid for providing services?
Yeah, good question, but unfortunately, no. That was not allowed under the aging waiver, and that is still not allowed under CHC. So somebody cannot have a spouse be a paid caregiver, or someone's power of attorney or other legal representative cannot be a paid caregiver under CHC.
Okay, then that's it.
All right, well, thanks everyone for staying with us, especially hanging on a little bit longer. We will follow up with you about a couple things if we can find some answers to that, and we'll get it out to everybody who registered for today's training. So thank you very much. Thanks for all your good questions too. And thank you, Kayla.